This recording is about anxiety and somatic disorders. Anxiety disorders. So anxiety, it's emotional response to some type of danger that we perceive. We usually are not really sure what we're anxious about, but it's just that feeling that there's something. Um, it's different from fear. Anxiety is more of an emotional response. Fear is more of a cognitive response to a known source. So we do have to have some anxiety in our life to survive. It's not the same as stress, but we do have to have some anxiety or because that's what keeps us moving, makes us do what we need to do. Mild anxiety does that. It's only when it gets pathological, when it interferes with our ability to work, to our social life, our relationships, and we are unable to function. So Hildegard Peplow, she is the one who had the theory of the nurse-patient relationship and how that went. She also has other theories, and one of these is a level of anxiety. And she puts anxiety into 4 different levels. Mild anxiety, this is where we want to be. We learn better when we're mildly anxious. We're more productive. Our senses are more alert, and we're more aware of what's going on around us. Um, if you're going to take a test, this would be a great place to be in because you'll do better. Moderate anxiety, you're less alert. Your attention span is decreased, your ability to concentrate is decreased, and you may feel restless. Severe anxiety happens when our attention span is very limited. We can't really complete things. We may go from one thing to another thing, and you're going to see more physical symptoms here. Maybe sweaty palms, maybe some chest pain, maybe some excess sweating, GI symptoms. And then panic level is the most anxious, and this is when you're totally unable to focus, lose contact with reality, what's going on around you, can't communicate, and really can't function at this level. Safety is the big thing for panic level anxiety. The person can't learn anything in that panic mode, so trying to teach them deep breathing is not going to be helpful. Um, that's something that maybe when they are less anxious, you could work on teaching them. But at the panic level, all we can do is make sure that they stay safe until that panic level kind of resolves itself. So some statistics. So anxiety disorders are the most common psychiatric illness, and they are disabling. Rates are 2 females to every male, and there's probably a familial predisposition. So there's probably some genetic link here. Minority children and children from low socioeconomic environments are at greatest risk, but I think probably anyone in these environments are going to be at more risk because they're going to have more things that are anxiety producing, maybe going on in their lives, not having enough food, maybe not having enough money, maybe the neighborhood where they live is not the best. So those are all things that can make your anxiety worse. So the pathophysiology of anxiety in the brain, GABA It's a inhibitory neurotransmitter that kind of damps down things in the brain. It seems to be that it is decreased when you have anxiety. And so that allows the areas in your brain to become excited, and that leads to that anxiety. Serotonin, we think, is decreased, and norepinephrine is increased. There's a nice picture in your book of areas of the brain that are affected by this decrease of GABA and kind of shows the functioning of that. So generalized anxiety disorder, probably the most common diagnosis with anxiety, GAD, um, chronic, unrealistic, and excessive anxiety and worry. Must be more days than not for at least 6 months before it can be diagnosed, and it needs to cause significant impairment in important areas such as your social life, your job, your relationships with others. Panic disorder is another diagnosis. This is recurrent panic attacks. The person doesn't know when they're going to start, so they're um, always worried about, am I going to have another panic attack? Um, the panic attack causes apprehension, fear. Sometimes they feel like they're going to die, impending doom, something horrible is going to happen, and there's a lot of physical symptoms at this point. Um, Agoraphobia may be also associated with this, and we'll talk about agoraphobia in a couple slides here. So predisposing factors for panic disorder. The psychodynamic theory, this is a Freud conflict within our own psyche. Cognitive theory that our thinking patterns are either distorted or faulty, counterproductive, and that the anxiety is that we have because of our thinking patterns causes this to happen. And then there's possibly genetics, the anatomy of our brain, the chemical makeup of our brain that predisposes us to have these issues. So phobias in general. Phobia is a fear that is um, caused by the actual presence of an object or a situation. So this is not just a stressor or a thought. This is actual um, object or situation. It causes an immediate anxiety response, or it can cause a panic attack, and it causes the person to either avoid the object or avoid the situation. The person recognizes that maybe this fear is over the top, maybe it's not reasonable, but they can't control the response that they're having to it. And here it talks about agoraphobia, and this from the other slide often is found with people who have panic attacks. It's the fear of being in places or situations where you can't escape from, or where you cannot get any help in case you start having these panic-like symptoms. Um, so you may avoid things like traveling, being in open spaces, going places like shopping, theaters, standing in line, being in a crowd, or just being outside your home alone can be an issue. Um, a lot of times people with panic disorders, they will start avoiding places where they have had a panic attack. So if they have a panic attack at church, they may stop going there. If they have a panic attack, let's say taking their kids to school, then maybe they don't want to do that anymore. Maybe they went shopping and had a panic attack, so they don't want to go shopping anymore. So they start isolating themselves more and more in order to prevent them from having another panic attack because of the fear of having uh, that attack. So it can get to the point where people don't even leave their own home because they're concerned that if they do, they could have another panic attack. So other phobias, social phobia or social anxiety disorder is pretty common, and a lot of people have this, maybe not very seriously, but maybe they're afraid of public speaking, of how people are going to receive them. Um, Maybe they don't like to go to parties because they're think, well, maybe people won't approve of how I'm dressed. Maybe I'll do something and I'll be embarrassed in front of other people. So they may avoid these situations just simply because they're concerned that um, people are going to look negatively at them. There's a whole lot of different phobias, and there's a big list in your book, like arachnophobia, the fear of spiders. Um, they all have a little name for the type of phobia. Um, you can't, it has to be a criteria for phobia where you have this intense fear, not just something you really dislike. For phobias, also, there's some predisposing factors, and these are pretty similar to the ones for anxiety. The psychoanalytic, some unconscious fears, we really don't know what they are, but we have fear. Learning theory, something that we have been exposed to before. A cognitive theory, something that comes up in our thinking. And then there's biological aspects to do with maybe our brain structure, our brain chemicals, and then experiences that we've had in our life that have been fear causing. So there are some medical conditions that can cause anxiety, and a lot of times anxiety can look like some of these medical conditions. So again, we may have to look at, before we decide it's anxiety, we need to look at some medical conditions. Someone who goes to the emergency room and believes they're having a heart attack because they're having chest pain, they're sweaty, they're short of breath, um, they're very anxious because they think they're having a heart attack. We have to rule out that they're not first, but anxiety, those symptoms can be an anxiety attack or it could be a cardiac issue. The endocrine system, some medical conditions there, the fight or flight syndrome can cause those neurochemicals. Um, Respiratory issues, neurological issues, and then substance-induced anxiety. Um, Either withdrawal from the substance or intoxication from the substance can cause anxiety to be evident. And this is obsessive compulsive disorder. This like we talked about the obsessive compulsive personality disorder, this is really different. This is not just wanting things in order. This is something that is a very serious illness. It can be very disturbing to your life. So there are recurrent obsessions or compulsions that are severe enough to be time consuming, cause a lot of distress, or impair your ability to do the things you want to do in your life. So an obsession is a recurrent thought, impulse, or image. It's intrusive, it's stressful, and you can't stop doing it just because you can't reason or logic it away. Like if I touch the handle of the sink when I'm washing my hands, I'm going to be contaminated again. I'm going to have to wash my hands again. Um, those compulsions, ritualistic behaviors and thoughts, And that's why people do these things over and over again, is to reduce the distress and prevent some of the dreaded events or situations. So the hand washing again, if someone is repeatedly washing their hands, as soon as they touch something else, then the distress is, oh my gosh, I've contaminated myself again, so I have to go back and I have to wash my hands again. So that's kind of an ongoing thing. If you think of how hard it would be to not touch anything after washing your hands, it's almost impossible to do. So that's why this happens over and over again. And the compulsion is used to decrease that distress. So if we try to stop them from doing that, that can cause them even more anxiety and distress. So they have a reason for those, and it's a slow process to stop that behavior. Body dysmorphic disorder is another anxiety disorder. This is the belief that your body is deformed or defective in a specific way, like maybe your nose is too big or something. If there really is a defect, the person has a exaggerated opinion of that. Maybe nobody else would notice that, but they feel that it's there, and it may not even be a defect. It may be perfectly normal, but they are seeing that this way. Um, and they want to change this. This is somebody who has maybe lots of plastic surgery or wishes they could have a lot of plastic surgery because they think that, well, if I could just change this deformed part of my body, things would be better. These people usually have a lot of depression, and they are likely to have some obsessive compulsive personality disorder traits also. Trichotillomania, the hair pulling disorder. This is someone, usually it is females, and younger females are usually the people who you see this most in. And this is someone who has lots of anxiety, and they're relieving that anxiety by pulling out their own hair. It can result in noticeable hair loss, and the person may even pull their eyelashes and eyebrows out, but the activity is to decrease their anxiety level. And then hoarding disorder. We may not feel like, we've seen what hoarding looks like, and we may not really think of it as a mental illness, but the DSM-5 does talk about hoarding disorder as being a mental health condition. This is a persistent difficulty of getting rid of anything, um, parting with any of their possessions, and it doesn't matter if they have any value or not. Sometimes people will just save trash, and they can't throw anything away. This can cause a lot of issues. This builds up that may be an unsafe living condition. If the person who's hoarding has children, it may affect their ability to keep their children in their home. It may cause danger if there's a fire, or if there would happen to be a medical emergency and they would need to get maybe paramedics in the house. It could be a real problem. So there's several statistics here that are they're kind of hard to believe that there are 700,000 to 1.4 million Americans who have a hoarding disorder. Um, Many do not get treatment. So even if they do get treatment, it is very difficult because getting rid of the objects that they are hoarding causes extreme anxiety. Um, the relapse is really high. Even if the person does get treatment, a lot of times they just um, rehoard other things, just kind of going back into the same behaviors, even if they have managed to get rid of all the things that they were hoarding. The it kind of goes back and the same problem again. And this slide just some predisposing factors to OCD and the related disorders, and they are really similar to the anxiety disorders, generalized anxiety. The psychoanalytic, this is kind of the Freud theories. Learning theory, maybe it's a response to a traumatic event that's happened. Um, Psychosocial influences, living arrangements, um, biological aspects, things in the brain, genetics. There could be possibly a genetic predisposition also. This slide just gives you an idea of what nursing diagnoses might be related to anxiety. And a lot of these would cover all of them: ineffective coping, ineffective role performance. Anxiety itself is a nursing diagnosis. It's also a medical diagnosis. Um, so things we want for outcomes for this, we want the person to, as a short-term goal, to understand their illness, to start working on methods of coping, finding out what works for them, and trying out different methods that maybe they haven't used in the past. And the long-term goals, we want to increase their level of functioning, use those coping skills, and then specific goals related to which illness they have. Do we want them to stop um, acquiring things because they're a hoarder, and start to get rid of things in their house that they do not need? Do we want them to start working on anxiety for a body dysmorphia? Do we want them to start seeing that their body is not deformed? So they're real specific for each client and for what type of disorder that they have. And what type of nursing interventions are work well for this population? Well, coping skills always, teaching coping skills, teaching them to change their thinking. That CBT um, is very helpful. So changing your behavior by changing the way you think about a situation. And then other things like, exercise, music, um, muscle tension and relaxation. There's lots of things that we can do for relaxation, um, and to help with the anxiety and decrease that. So it'll be individualized for each person, which works for them. So that may be something in those nursing interventions that obviously you want intake from the person on what they want to do and what they think will work for them, and then just having them practice and seeing what is effective. So both the client and the family need information about um, the nature of the illness, what causes it, how to manage it. Um, if they're taking medication, what are the things that we need to know about the medication? Stress management techniques, and then support services. What things can we get to help them? So treatment for these anxiety disorders: individual therapy, group therapy, cognitive behavioral therapy, and then this behavioral therapy, a couple of different ways that are used to treat phobias. systematic desensitization, and implosion therapy or flooding. Systematic desensitization is a slow process where the person identifies what is causing their fear, and then they move slowly with the goal of being able to deal with whatever their phobia is. Um, let's say a person was in a bad car accident, and maybe they're afraid to even get in a car. They were driving and something terrible happened. So they're afraid even to get in a car. They don't even want to do that. So systematic desensitization, um, maybe they would sit in the back seat of the car, um, and just sit. The car wouldn't move, and they would just sit. When they are comfortable there, maybe they'd move to the front seat and just sit, and car wouldn't move. And then maybe they would have someone drive them somewhere. Um, and then once they're comfortable with that, maybe they would drive with someone with them. And before they got to that final point where they were able to drive themselves again. Implosion therapy is just throwing somebody into what they're scared of, just right there, what the phobia is. It reminds me of the Fear Factor show. Just throw you right in there. And the thought is once you've had this panic, you can't stay panicked forever. So that response will slow down, and you will be able to calm down, and you will have faced this phobia. Um, I think probably systematic desensitization would be much more comfortable for the person. So pharmacology treatments, anti-anxiety medications. So a lot of these anti-anxiety medications are um, benzodiazepines. They do potentiate GABA, so increases the amount of available GABA to inhibit the brain, and they depress the CNS. Buspirone is a exception to this. It does not depress the CNS. Its effects come through serotonin, dopamine, and some other neurotransmitters. So it is a different type of medication. It also does not work as quickly as the benzodiazepines, so that's a little bit different. So here is a list of the medications. You see buspirone at the bottom, Buspar. Patients need to know that it is going to take 7 to 10 days at least before they start to get the full effect of this medication. Some of these end in PAM, clonazepam, lorazepam, oxybazepam, diazepam. Those are the benzodiazepines, and a lot of them you can tell by looking with the PAM at the end. Not all of them have PAM at the end, but a lot of these do. Um, they work very quickly. Um, 15 minutes, you can start to see the effect of these. So it's important for patients to know that the Buspar is not going to work that fast, because if they're used to taking like a benzodiazepine, they're going to feel like this isn't working for me because I'm not getting any response because they're used to having an immediate response. The problem with the benzodiazepines is they are addictive. Um, Withdrawal from benzodiazepines can cause seizures. So you have to, if you've been taking them for a long time, you can't abruptly quit taking them. So they have to be weaned off of them. Um, they work very well, but they do have some down symptoms there that don't work as well. Another type of medication that works for anxiety that does not do any of this is the beta blockers, drugs like propranolol. What they do is they decrease the pulse and the blood pressure, and when those come down, then there's less of those anxiety feelings that the person has with the rapid heartbeat. And um, so they are very good for people who either don't want or shouldn't be taking something that is addictive. So you'll see people taking some of those beta blockers for that. This slide just kind of goes over some of the side effects. Some of those are already talked about. They can make you drowsy, confused, lethargic, hypotension. This is especially problematic in the elderly. Um, it potentiates other CNS depressants, so you want to be careful with other things that depress the CNS, opiates, alcohol. And you can, for the benzodiazepines, you can get a tolerance to them, so you need more of a dose to get the same effect. And you may have physical and psychological dependence on them. Um, they can also cause paradoxical excitement in some people. Some people don't get the anti-anxiety effect from them. It actually kind of ramps that up. Um, Dry mouth, nausea, vomiting, those are all symptoms that can happen. And blood dyscrasias or issues with the blood, especially with long-term use. So, somatic disorders. These are people who have medical complaints that can't be validated by any testing, labs, x-rays, um, even when they are given proof that there is nothing wrong with them, they're still convinced that they're ill. Anxiety and depression are very common comorbidities of this. It's a chronic illness, and there's some more information about the diagnostic criteria in your book. Um, these kind of come in periods. They may have a slight remission, and then it'll be exacerbated again. Sometimes because of some anxiety producing thing that's going on with them. So illness anxiety disorder, um, this is an actual physical symptom that is not interpreted correctly. So someone who is fearful because they're having headaches and they think they have a brain tumor. Um, so they may go to one doctor and the doctor, does testing, says, no, you don't have this. So they'll go to another doctor because they had to be wrong because they know something's wrong with them. The depression, anxiety, and OCD traits are also common with this disorder. Um, and there's a lot of anxiety with this. They can have an exacerbation simply by knowing somebody who has a serious illness or just hearing about it, someone talking about a serious illness. So why the somatic disorders deal with like somatic body, GI, respiratory, cardiac, neurological symptoms. Conversion is neurological functioning. So there's a loss or a change in body function. A lot of times this comes after a traumatic event. This could be um, paralysis of part of the body, inability to speak, inability to see, pseudocyesis, which is a false pregnancy, pseudo seizures, which are seizures where there is no change in the brain, and again, this can only be diagnosed through a medical evaluation. You have diagnostic criteria in your text that you can look at for this. So this is neurological symptoms. The somatic is body, general body symptoms. So some predisposing factors for the somatic disorders and the conversion disorders. Um, believe there's something genetic to this. First degree relatives who have this issue are more likely to have other people who have this. Um, biochemical issues in the brain, um, changes in the brain structure, um, then traumatic events that cause low self-esteem, feeling worthless, um, and then family dynamics, negative ways in the family of dealing with emotion and learn things, reinforcement of symptoms by primary or secondary gain. And with this, people aren't really they're not aware that they're looking for this secondary gain or primary gain. What they just know they have these symptoms, but they're not trying to be ill. It's a part of the disorder itself. So the best thing in treatment is when the patient is able to look at their thoughts and their feelings and to correlate them to the physical or neurological symptoms that they are feeling. So support from the nurse can help this, help them to focus on when they're having the symptoms. What are you thinking about? What are your thoughts? How are you feeling right now? Are you anxious? Are you depressed? Are you worried about something? And how that correlates with the symptoms that they're having. Now, if they have like a paralysis or some other type of disability because of this, we do have to help them with that. We want to make sure that they're safe, but we want them to be able to explore their feelings and finding a different way to cope with them other than to have uh, physical symptoms. There's also some information in your module about factitious disorders. Factitious disorders used to be called Munchausen's and Munchausen's by proxy. And these disorders, the patient is aware that they do not have the symptoms or the disease that they have. And by proxy means that they are projecting these onto another person, maybe a child, maybe an elder, and doing something to cause either themselves or the person to get medical care. And the medical care is to make them feel like they're being cared for. So it's a secondary gain looking for attention and support from medical personnel, even though they know that there is nothing wrong with them. So that's kind of the difference between somatic disorders and factitious disorders, is the fact that in somatic, it's not because the patient wants the attention and support, it's because they actually do feel like there is something wrong with them. They believe that. Factitious disorder, they know there's nothing wrong with them or the person they are using for a proxy, but they are looking for the attention and gain that they can get from these physical symptoms. And that is pretty much all for week 3 in this area.